to date, the immune therapies have seemed to work better in the different group of people than where the targeted drugs have worked. There was some data at ASCO this year looking at tumor mutational burden as a marker other than PD-L1 about who's going to potentially respond the best to the checkpoint inhibitors. And so if you think about the fact that the patients with the single driver mutations tend to be the least complex tumors, and that was actually borne out in that analysis, we're not really sure how to bring them in. So it's very unlikely that the immune therapies are going to be first line in patients with targetable mutations. Are they going to be second line in combination with targeted agents or with other immune therapies? Maybe, but we can't forget about chemotherapy. Chemotherapy still works pretty well too in that group of patients. So there's a lot of exploration still to be done, and I think we just need to see these data mature from the combination trials that are being done. The chemotherapy combination trials that were presented here with pembrolizumab in addition to chemotherapy were quite intriguing. One of the things that has come out is the carboplatin plus pemetrexed with, in this case, pembrolizumab, response rate was nearly 70%. And that was actually seen also with atezolizumab and work that was presented last year in that same combination, and also quite good with other chemotherapy combinations. So I'm personally really intrigued by the chemo plus combinations, but also by a lot of the new immune therapy combinations. So we'll see how that all pans out too.